Okay, so I'm Lee Wallis. I have a number of roles. So my day job is Head of Emergency Medicine for the Western Cape Government in South Africa. So I have 41 emergency departments and work within the ambulance service and responsible for quality of care in the ambulance service. I also am academic head of two divisions of emergency medicine, one at the University of Cape Town, one at Stellenbosch University. So undergraduate training and then postgraduate training and research. And then I'm immediate past president of the African Federation for Emergency Medicine, which is the African Regional Professional Society. And I'm currently the president of the International Federation for Emergency Medicine, which is the global body for professional societies. Through my academic role here in Cape Town for the last 5 years or so, I've worked with Karolinska Institute Department of Public Health on M-Health in acute trauma care. Particularly, we've been using burns as an example to try and prove a concept and do research around the use of M-Health in emergency care in general.
So how did you make the entrance to M-Health? I mean, were there obvious things that were better than the traditional approaches?
There were obvious things that were better than the traditional approaches, yes. How I ended up with this focus was just really from the... So it's a complicated answer. Clearly, M-Health is helpful, and we'd identified it as something people started to use 5 years ago. My team was starting to use their phones more and more in everyday clinical practice. To transfer that into a research focus actually needed Lucy Laflamme and her team from Karolinska were, I guess that, I don't remember the exact details, but they had some funding to try and do some of this work with the Medical Research Council. Then they met a couple of people in Cape Town looking for a relationship for the study, and then they met me and I was intrigued. Something that we clearly were using every day, there was a need for it, and here was a partner that we could work with and could actually push the research. So I think we've now got 9 or 10 scientific articles, we've got 4 PhD students, got master students, all of which came from that meeting with Lucy and Marie, which just allowed us to funnel something that clearly we needed to be doing. We just didn't have the resources to do it.
And now, what's the next step? How do you take that research to larger scale implementation?
Well, that's what, yeah, but that's what our research is. So we actually, one of the first things we did was have a meeting at World Health Organization in Geneva around how this recurrent issue of M-Health projects being at pilot stage only and not getting beyond that. So there was a good 2-day meeting at WHO where the sort of building blocks were laid out. And the building blocks are: you establish the need, you establish the fact that people are willing to use the technology, you develop something that is usable and you test that it's usable and you refine it, and then you measure its uptake and you measure the clinical impact. So our research has been around all of those 5 steps. We've done the first 4 steps repeatedly. What we've had, unfortunately, with our app was we had some delays in the development. Then it was only on Android and it was on dedicated phones rather than people's own phones. And in our setting, people wanted it on their own phones rather than a phone that's given to them and locked away. And so we had some speed humps that we hadn't expected, which has been very useful, and it's been a very useful learning experience, which we've tried to share that information as well. Now we've got it integrated onto the Vula app, which is I think we're now the 10th medical field on that app. It's used across the Western Cape. So now this year we're collecting clinical data on burn patients, those that have the app use them and those that don't, and we're hoping to see a difference in terms of, we're hoping, our hypothesis is that referrals will be reduced and the doctors using the app will feel they've done better management and that their management decisions will be changed by the app. So yeah, we're currently doing that research. The only thing that we're not doing, because we haven't been able to secure a grant for it, is the clinical outcome part, which is the really important part. It doesn't make a difference clinically. We're testing, does it change the referral and the management, but we're not testing whether patients get any wider benefit from it, as in, they heal sooner, they have less permanent disability, mortality is reduced, questions like that.
And what's your study population?
It's the size, or
what size and people?
Well, we did a sort of our initial baseline how many patients we're likely to get. We looked at a year's worth of patients at 8 hospitals out of our 41, and there were nearly 2,000 burn patients over the year. So we're using the app anywhere that wants to use it out of our 40-something hospitals. And wherever it's used, we'll collect that data. So we think by the end of the year we'll have a couple of thousand patients.
Okay. And you've added it already to the Vula app, so it's already a similar app being used for different conditions. But what do you see as the broader use of this particular app? Is there? I mean, how wide could it go in terms of conditions?
It can go. The good thing about the Vula app and why we were keen to latch onto it is it's got the image-based part of it. It's got a communication function, so a chat-based part of it, and it's also got a referral function built in. Because one of the issues we had, our previous app was almost identical. The flow through it was slightly different, but it was almost identical. And the one thing that delayed us again a little bit was Vula had to build in a drawing tool for us. So one of the things you do with burns, there's on your phone there's a picture of an outline of a person, and you draw in where the burn is, what you think the burn is, and it calculates for you how big the burn is and how much fluid you should give and so on. So we had that delayed us a bit. So the Vula app has all that in now. What we were finding when we had it previously with our standalone app was that people were using the app to get the advice. They were getting the advice from me or an on-call burn expert, and then we'd say refer the patient. In order to do that, they had to pick up the phone and phone the burns unit and make it. So there were 2 separate processors, and people didn't like it, interfered with their function. What they would rather do is just pick up the phone, describe the burn, get the advice, and make the referral there and then. So Vula, in all of the specialties, it has the referral function as part of it. So you speak to they're not speaking to me anymore, they're speaking to the burn surgeon at the burns unit. So they get the advice from that person, they chat with that person, and they would get the referral from one spot. And they do that in orthopedics, cardiology, ophthalmology. There's a bunch of others. So that can just go, it can go into any field of medicine, and it can go into any hospital. So we're actually taking the same app. One of our PhD students just came on Friday from Dar es Salaam, from Tanzania. He's going back there in a couple of weeks. He's doing the first groundwork of acceptability. But our plan is, and in Karolinska they have funding for studying this now in Tanzania and Ethiopia. So using local burns experts, which is even fewer there than there are in Cape Town, using local hospitals in and around Dar es Salaam, and seeing whether people use it, doesn't make a difference to referral patterns and so on. So it not only could go across different fields, but it can go into different countries very easily. All you need is cell phone connectivity.
Have you found any challenges with training the healthcare workers to use it?
No. So again, our first version of the app, we had to go train people. We built a dedicated training manual. We found that the doctors were trained within 5 minutes. They're used to using smartphones. We had a harder challenge training nurses in rural areas because they weren't used to using apps on smartphones as part of their daily. So when you're looking at acceptability, you ask people, do you use it in your work, but also do you use it socially? So we found the nurses were using smartphones socially, but not at work. And so there was more of a training issue there. With Vula, because most of the clinicians are already using it for something else, it's the same entry into it. You choose burn someone over a list, and then it's exactly the same. You choose the doctor, you choose take a picture, you choose the chat function. So we haven't needed to train. And
language issues, is that an issue?
It probably is an issue. We've not addressed it yet. It will be an issue if it's going to go wider. At the moment it's just in English. In Cape Town, most of our referrals are supposed to be in English, our notes are supposed to be in English, so we've avoided that problem, but we're aware of it sort of in the background.
It might be an issue.
It will be an issue. We will need to address it at some point. I mean, the chat function, they can do it, there's no need for that to be in English. The drawing tool, the images, their language doesn't matter. What will matter is changing the entry, the text around entry, the text around the doctors, who's on call, the text around how you use it, things like that. So we'll eventually have to deal with that.
And there's been a lot of emphasis in the roundtable on the need for collaboration, transsectoral, multidisciplinary, all that kind of thing. And we have people here from lots of different sectors. But you brought up the issue of funding and how the funding models don't actually lead in that direction. Could you expand a little bit on that?
So this has been a soapbox issue of mine for a while, and I think probably why I don't get much funding. I think I irritate the funders by saying it. But the current university research funding system is designed, probably isn't the right word, but it's set up in such a way that it promotes people to be insular and to try and fight for their own research project at the expense of others. It's a sort of winner-takes-all system.
Competition, yeah.
So although some of the funding bodies now are actively putting out calls that say this has to be collaborative, it has to be cross-country, it has to be cross-disciplinary, those are still the minority. So what happens is we saw an image in a couple of the talks earlier today of Uganda in this before they introduced a moratorium on new pilots, and there were 50 mHealth pilots going on somewhere in the country, and no two of them were talking to each other, and they all had their own funding, they were all building from scratch. Probably a reasonable amount of duplication there, and we see that it's not just in mHealth, it's not just in emergency care, it's in all fields of medicine. The funding bodies want 100 applicants for their grants, they're going to fund 3 of them.
They're going to compare them, yeah.
Yeah, they're going to pick what they think are the best, and this isn't a criticism of the funding bodies, they're trying to fund the things that will make the best impact with the best science. The problem with the system is that it means that I want to put in the best for my team so I can pay my team's salaries and my team's infrastructure and my team's interests at the expense of yours or hers or his or theirs. And that way, it's difficult to imagine how a model would work, but about pooling and so on, because particularly if you look at US universities, they're not on government salaries where research funding just pays for phone calls and flights and things. Their salary is paid by the research. It's not quite the same here. Like I'm on a government salary. If I bring research funding in, it's not paying my salary, it's paying a number of other costs. But my job's still secure whether I get the research funding or not. So it's slightly different, but it really promotes, we are always in competition with other universities because people's livelihoods depend on getting the grant funding. And also their projects on the ground. If their project has been running and funded for 3 or 4 years and now the funding stops because they lose the bid, all those people on the ground in Ghana suddenly are unemployed. The system goes away.
You've lost the expertise.
So yeah, so there's a whole bunch of problems with it. Clearly, I'm not advocating that we should fund sloppy research or just pump good money into bad projects. There has to be a proper way of doing it, but the current system, it's set up in such a way that it promotes this adversarial, I want my money and therefore I'm going to push you guys aside, and it's very difficult. Which
is not ideal in a field like this that has to attract in different sectors.
And even you can then go into things like development aid. So a lot of my group's work has been funded from Swedish money. But as with all development aid, and Sweden's one of the most forward-thinking and open-minded countries around this, their development aid is actually very liberally applied. But even with that, nearly all of the money stays in Sweden, which is, it's great. I get the team coming over here, they do the research, there's data collection, I've got the very smart brains working on these sort of problems, which we wouldn't have without that money. But the money isn't it's not on the ground, so it doesn't fund any of my team's expenses, which there's a whole moral and philosophical debate about whether it should or shouldn't, but it doesn't. That's the reality. So we have to find other sources of funding, and usually when you apply and say, we're looking for whatever, R1 million, and they say, well, what are they funding you? Well, there's 5 million crowns coming from Sweden for this. Oh, well, you don't need our R1 million, but we don't get any of that money. So
exactly.
It's a very difficult situation. It's easy for it to sound like it's a criticism of the team over there or the funding agency. It's not. It's just the reality of how these things developed organically over 50 years. And it would take Herculean effort to stop and reset it, but someone's got to do something about it because it's not a healthy way of funding.